Okay, so good morning and welcome to all the students and postgraduates who were. I'm hopeful that you were there last time as well. So, Dimanda ki kichu bolben protome? Amulda, or shall I continue? শুনতে পাচ্ছো?
আমি শুনতে পাচ্ছি, সবাই শুনতে পাচ্ছে। আমার মনে হয় দিমানদার কিছু সমস্যা আছে।
তাহলে আমি আর করতে Okay. So again, welcome. And as you all know, morning time is a physical exercise time, but it's time now for some mental exercise. You know, acid-base disorder is always a good mental exercise, sometimes applicable at the bedside. So in the last lecture, I talked about the principles of acid-base disorder. So those who were present last time will be able to use that knowledge to do some practice sessions. And so to make it a little more interactive, Professor Ganguly is going to be here, and myself will be asking you to interpret the different examples that will be presented. So let's start with this one. A 60-year-old man with respiratory distress. So we'll give you about 5 to 10 seconds. If any of the postgraduates would like to interpret this blood gas, just don't hesitate, right, wrong. Just what do you think? What's going on with this patient? One of the problems with the online, I can't see your faces, so it becomes a little difficult. But if any one of you can volunteer, that will at least have the momentum going. So let me have this one myself. As you know, this is the pH PCO2 bicarb. We talked about the Anderson equation last time. So first of all, you have to make sure that this ABG is internally consistent. So in order to do that, we have to look at this and we have to calculate the hydrogen ion. And from that, we have to see whether the hydrogen ion is correct or not. And it is 80 minus the pH will be the hydrogen ion. So in this case, if this was the patient's PCO2 and bicarb was 24, so we come to 24 multiplied by PCO2 by bicarb. So that's the hydrogen ion is 60. So the pH should have been 80 minus 60, should have been 7.2, whereas the pH in this patient was 7.3. So this was a wrong ABG. The ABG machine did not calculate, did not measure it properly. In the modern ABGs, this won't be reported. This will come as a question mark. So that's why we don't do internal validity nowadays in ABG, because the machine is not going to report. So just for exercise purpose, might be worthwhile looking into it. Calculate the hydrogen ion and convert it into pH. 80 minus last two digits of pH will be hydrogen ion. So this was a error in ABG. Okay. So let's come to the second case. A 60-year-old patient in ICU with intestinal obstruction. His nasogastric output is 3 liters in 24 hours. And this is this patient's blood gas. Just concentrate on your pH, PCO2, bicarb. What do you think is going on with this patient? Any of the postgraduates? This is pretty simple. No, we discussed about the principles last time. কেউ বলতে পারবে এটার কি হতে পারে? বিমানদা এসছেন? বিমানদা জয়েন করেছে? কৌশিক?
না স্যার, এখনো জয়েন করেনি, তবে চ্যাট বক্সে অনেকেই রিপ্লাই করছে স্যার।
ও চ্যাট বক্সে করছে, দাঁড়াও।
চ্যাট বক্সে দেখো, টডি, এখানে কেউ বলছে মেটাবলিক অ্যালকালোসিস, আবার কেউ বলেছে রেসপিরেটরি অ্যাসিডোসিস। তুমি চ্যাট বক্সে দেখো, some PGTs, they are interacting.
কিন্তু জানো তো আমি যখন প্রেজেন্ট করছি স্লাইড তখন কিন্তু আমি চ্যাট বক্সটা দেখতে পারি না। প্রেজেন্টার না, প্রেজেন্টার চ্যাট বক্স দেখতে পারি না, তাহলে মানে আমি তো দেখতে পাচ্ছি না। দেখি, হ্যাঁ দেখছি, এক সেকেন্ড। হ্যাঁ এবার আসছে, হ্যাঁ এবার আসছে।
You are entitled to see the chat box.
কেস 1 সবই রেসপিরেটরি অ্যাসিডোসিস, কেউ মেটাবলিক অ্যালকালোসিস, কেউ মেটাবলিক অ্যালকালোসিস। ওকে গুড। তাহলে দেখো, I think most of you are correct in the sense that the simplest way is first of all, it is alkalosis because pH is 7.49 and CO2 is 47, that is more than 40. So this is metabolic alkalosis. And as we said, the last 2 digits of pH, if it is equal to PCO2, then it is simple metabolic alkalosis. So most likely this is simple metabolic alkalosis due to continuous nasogastric output, because the acids are getting lost here. So this is simple metabolic alkalosis. 49 would have been ideal, but plus minus 2 is accepted. So look at pH. If it is alkalotic, look at CO2. If it is high, it is metabolic alkalosis. And last 2 digits remaining the same is the simple metabolic alkalosis. We will discuss it later on because otherwise we won't have much time to discuss pro and cons of each. Let's go to some more complicated acid-base situation. A patient with an unknown past history presents with respiratory distress. Arterial blood show pH 7.32, 70, PCO2 bicarb 34. Now, can somebody tell me what's going on here? এটা কি হতে পারে? ওরা সব লিখছে না, এটা কি আনমিউট করা যায়? যারা যারা বলতে চায় ওরা নিজেরটা আনমিউট করে বলে যদি মিউট করে দেয়। কৌশিক?
না স্যার, ওটা পারবে না। কেন? ওদেরকে ওটা অ্যাটেন্ডিতে রাখা আছে, ওরা স্যার লিখেই রিপ্লাই করতে পারবে।
ও,
যেমন ক্রনিক রেসপিরেটরি অ্যাসিডোসিস বলছে।
ক্রনিক রেসপিরেটরি অ্যাসিডোসিস, আচ্ছা রেসপিরেটরি অ্যাসিডোসিস আর কি হতে পারে? Metabolic acidosis with respiratory acidosis. Sure. Okay. So let me discuss about this. There are a few possibilities here. First of all, this is pH is low, so this is acidosis. PCO2 is high, so this is respiratory acidosis. Now, as we discussed about last time, the rule of 1, 2, 3, 4. For each 10 millimeter rise or fall of PCO2, bicarb will change in acute respiratory by 1, acute respiratory alkalosis by 2, chronic by 3, and chronic alkalosis by 4. So let's apply this rule here. Now, as we said, this patient definitely has respiratory acidosis. If it was chronic respiratory acidosis, carbon dioxide was 70 in this patient. So it has risen by 30. So instead of 40, it is 70. So bicarb should rise by, if the normal bicarb is 24, for each 10 millimeter rise of CO2, the bicarb should rise by 3. So it is 9. So it should have been 33. So one of the right answer would have been that this is pure chronic respiratory acidosis because the bicarb was 34. In chronic respiratory acidosis, it should have been 33. So it's more or less same. But you see, there could be another possibility. In acute respiratory acidosis, for each 10 millimeter rise of carbon dioxide, bicarb rises by 1. So if carbon dioxide have increased by 30, bicarb should have been 27. But this is 34 here. So this could be acute respiratory acidosis plus metabolic alkalosis. Because as you see, this patient has an unknown past history. We don't know which one is which. but both of these would have been the correct answer. The example would be, the first one would be COPD with mild exacerbation, no superimposed respiratory acidosis. And the second one would be acute attack of severe asthma, so acute respiratory acidosis, and metabolic alkalosis due to theophylline-induced vomiting. So both are possible. Without knowing the case, you will not be able to know exactly which case is it. So a physical examination of this case, if it fits in with asthma, then this might be the case. If it is more of a COPD, then this might be the case. So you have to look at the patient and then decide which one of your explanation is the correct one. So always look at the clinical context. Let's take this case. Again, an unclear past history presenting with respiratory distress. Now, this is the ABG, 7.27, PCO2 70, just like the previous case, but the bicarb here is 30. We'll give you some time just to look into this. What are the possibilities here? How can you explain this problem? Acute respiratory acidosis, okay. Acute respiratory acidosis plus metabolic alkalosis. Most of you are saying acute respiratory acidosis with metabolic alkalosis. Somebody is saying just acute respiratory acidosis. Okay, so looks like everybody is agreeing at least to respiratory acidosis, which is correct. pH is low, CO2 is high. But is it acute? Is it chronic? Is it something else? So let's analyze this ABG. So it's respiratory acidosis, we agree. Now, if this is acute hypercapnia, just like in previous example, then 30 millimeter of mercury's rise in CO2 should increase bicarb by 3. So should have been 27 instead of 30. So unlikely to be just acute respiratory acidosis, if anything, acute respiratory acidosis with metabolic alkalosis. Now, if this is chronic hypercapnia, the serum bicarb should have been increased by 11 to approximately 35. So, but this is 30. So it's somewhere between 27 and 35. 30 is the bicarb. So what are the possibilities? One is definitely acute respiratory acidosis with metabolic alkalosis, or this could be chronic respiratory acidosis with metabolic acidosis, that the bicarb has reduced from 35 to 30, like a patient with COPD who has developed diarrhea or has become septic, so they can have a lower bicarb than what is expected of chronic respiratory acidosis. The third, and this one we mentioned, acute respiratory acidosis with metabolic alkalosis. But this is also a possibility. Acute respiratory acidosis superimposed on mild chronic acidosis. This might be the most common example. Suppose this patient had a COPD, had a baseline CO2 of 55, and the bicarb was appropriately 30, and probably this patient's pH would have been normal. Now this patient develops pneumonia and his PCO2 has risen to 70, sudden rise of PCO2. The serum bicarb would increase by say 1 milliequivalent per liter, 1 to 2 milliequivalent per liter. So this would be a slight acute on chronic respiratory acidosis. So this is the way you should look into these kind of blood gas. There are three possibilities. This could be, if, and without knowing the patient again, you won't be able to say, is this simple acute respiratory acidosis with metabolic alkalosis? Or is it chronic respiratory acidosis with metabolic acidosis? Or acute on chronic respiratory acidosis? All three would explain this kind of a blood gas. The bicarb might be plus minus here, 2 here and there, But that is the way to interpret this blood gases. So the main message from these two examples is just don't go by the numbers here in the blood gas. Look at the patient. There are so many ways you can explain this. Given the formula, yes, respiratory acidosis everybody would have, but this second component is the main one. This can only be explained by looking at the patient, and you would be able to basically justify your explanation given what is the patient's background. So again, coming to the main theme, that look at the patient and then decide what could be your explanation. So correct diagnosis only by history and physical examination, not just by the blood gas. Okay, so those were the respiratory acidosis problems that we just discussed. Let's come to some metabolic problems. A patient of multiple myeloma with and asthma has presented with this problem. He has a pH of 7.23, bicarb of 19, and PCO2 of 47. As you could see that immediately after looking at the pH and the PCO2, you know this patient has respiratory acidosis. You don't have to do any calculation to say that this patient has metabolic acidosis. The reason is, in respiratory acidosis, the bicarb should have been high. As you know, in all acute or chronic respiratory acidosis, the bicarb should be more than 24. But in case of respiratory acidosis, if bicarb is 19, then there has to be some metabolic acidosis component. So just by these three numbers, you immediately know this patient has respiratory acidosis with metabolic acidosis. No calculation is needed. Now, the second question is, what kind of metabolic acidosis does this patient has? So if somebody can look at it and tell me. So this is metabolic acidosis with a respiratory acidosis, we agree. Now, what kind of metabolic acidosis are we talking about? Normal anion gap acidosis. Okay. High anion gap metabolic acidosis. So we got two answers. One is high anion gap, one is saying normal anion gap. Interesting. Non-anion gap, high anion gap. Okay, so it looks like there is a division of high and normal anion gap acidosis. So first and foremost, you need to know what would be the normal anion gap in this patient. And as you all know, normal anion gap is 12. Now, if normal anion gap is 12, that has to be corrected for albumin and that has to be corrected for pH. So normally the anion gap will come down by hypoalbuminemia and by acidosis. So in this patient, the normal anion gap is 6, not 12, because for low albumin, you have to correct. So albumin is 2. For each gram of albumin coming down, anion gap comes down by 2. And for acidosis, it comes down by 2. So you have to minus 6 from this. So any calculation of anion gap in this patient should start with a normal anion gap of 6. So what is the actual anion gap in this patient? Is sodium was 131, this was chloride, this was bicarb, and this is 7. So this patient has a normal anion gap acidosis. If you would have taken as 12, then you would have said this is high anion gap acidosis. But just look at the albumin and look at pH. Look at albumin and look at pH to know what is the normal anion gap. So this is this patient has a normal anion gap acidosis. What could be the reason for this? Anyone? Given this case, what could be the reason for this normal anion gap acidosis? Why this patient would have developed a normal anion gap acidosis? sodium chloride correction. There's no history of giving decay, renal failure. Renal failure is high anion gap, decay is high anion gap. We have normal anion gap acidosis. Okay. কৌশিক একটু মিউট করো, কারো ব্যাকগ্রাউন্ড চলছে দেখছি। Okay, so before we go to this normal anion gap acidosis, there is another way, as I mentioned in my first talk, a much simpler way to analyze this. Just look at sodium and look at chloride. If it is less than 40, this patient has metabolic acidosis. If it is more than 40, the patient has metabolic alkalosis. Whatever else are the value, this is called the strong ion gap theory. So 131 minus 104 is 27. So this patient has metabolic acidosis just by looking at sodium and chloride. This patient has metabolic acidosis, is less than 40. And I think this is one of the most important diagram that you should remember. This difference between sodium and chloride has to be explained by albumin and bicarb and 5 strong anions, which even if we don't consider phosphate. So albumin, for each gram of albumin, you have to take 3 milliequivalents, and bicarb. So if we take this patient, the strong ion difference was 27. So I have to explain this 27 by bicarb and albumin. This patient's bicarb was 19 and albumin was 2. So I have to, for each gram of albumin, I have to add 3 milliequivalent. So 6, so 25. So this becomes non-anion gap acidosis. That means even if I add the normal strong anions like sulfates and all that, so this patient does not have any other anion in order to explain this 27. This 27 can be explained just by patient's bicarb and albumin. So straight away, just by looking at the sodium, the chloride, and the albumin, I can say this patient has normal anion gap acidosis. Okay. So now the question comes, why this patient has non-anion gap acidosis? Why this patient has non-anion gap acidosis? If anybody, remember this is a case of multiple myeloma. Always go back. Yeah, I think somebody has answered as renal tubular acidosis. So how do we know it is renal tubular acidosis? We have to do what is called urine anion gap. So this urine sodium is 147, urine potassium is 27, urine chloride is 146. So urine anion gap was plus 27. So if you have a positive urine anion gap, this is RTA. In diarrhea, you get a negative urine anion gap. So remember, urine anion gap, in diarrhea, you get minus 20 to minus 50. In RTA, you get plus 20. And this is the, in normal urine anion gap is also positive. We won't go into details of the explanations of this, but for the time being, it is suffice to say that this patient has renal tubular acidosis because he has a positive urine anion gap. So basically this case is, and how do you know what type of RTA is this? This is this urine pH. Can anybody tell me what type of RTA? You have to look at the urine pH to know the type of RTA. Type 1, because in renal tubular acidosis type 1 or distal RTA, urine pH is more than 5.5 and serum potassium is less than 4. So this patient, if you look at the entire case, a multiple myeloma with asthma presented with distress, has respiratory acidosis, may be due to asthma, may be dyspnea due to metabolic acidosis, and has a non-anion gap metabolic acidosis due to type 1 RTA. So you have to give bicarb to this patient most likely to correct this. As you know, myeloma can cause renal tubular acidosis. So in order to analyze these patients, the whole thing, you ideally would require the urine electrolytes, and you will also require the serum electrolytes. So you see, so many interpretation can be made by these numbers, and this has to be taken back to the patient's bedside and see how do we help this patient. Okay. So that was one of our complex cases of metabolic acidosis. How do you analyze an ion gap? How do you use Stewart's equation to simplify your metabolic acid-base problem? How do you identify an underlying non-anion gap acidosis? And how do you differentiate the causes of non-anion gap acidosis? Okay. Now let's take this case. A 40-year-old man with a history of alcohol abuse is brought to the emergency department with altered mental status. Alcoholic with an altered mental status, he's febrile, jaundice, ascites, has leukocytosis, mild anemia, thrombocytopenia. This is the sodium. Creatinine is slightly high. Urine shows 3+ ketone. Chest X-ray shows right lower lobe infiltrate. And this is this patient's anion gap is given to you. So this is this patient's anion gap. This is pH. This is PCO2 by. So what do you think is going on in this patient? There was one question asked in the previous explanation. Urine electrolytes at spot. Just send 510 cc of urine and just measure sodium potassium chloride. So in this answer is high anion gap metabolic acidosis, mixed respiratory and metabolic acidosis. Okay. Now what type of high anion gap acidosis is this? There are so many possibilities: lactic acidosis, alcoholic ketoacidosis, starvation ketosis. You might have taken an adulterated alcohol or antifreeze. So how do you differentiate which one? Which one does this patient has? Yes, he has high anion gap acidosis. That's pretty obvious with this anion gap. His pH, last 2 digits of pH CO2 is almost, so this might be just pure metabolic acidosis. There might be some component of respiratory acidosis, but mostly pure metabolic acidosis. So what else do we need to know in order to differentiate the causes of high anion gap acidosis? What else do we need to know? Anyone? You say lactate, okay, that will exclude lactic acidosis. Anything? Plasma osmolality. Yeah, I think that's the correct answer. Not only plasma osmolality, you have to look at the osmolar gap, because plasma osmolarity will be high in this patient for many reasons, but osmolar gap is important. So this is a normal osmolar gap. So if this patient lactate was 2.5, he didn't had ethanol in the blood, osmolar gap will tell you whether there is methanol or not. So it's important to look at osmolar gap. Osmolar gap would have been high in this patient. Osmolar gap is calculated, measured minus calculated osmolarity. So the elevated anion gap is a result of ketone body production due to suppressed insulin secretion and lipolysis, in part to alcoholic metabolism. You see, alcoholic ketoacidosis and starvation ketosis go side by side. Most of the alcoholics are malnourished, and they can cause a lot of lipolysis due to suppressed insulin secretion. In addition, a mild lactic acidosis can be present due to volume depletion. History is the very important to know toxic alcohol ingestion. and there will be elevated osmolar gap. This is a very key exam question. They will give you isopropyl alcohol. It does not cause acidosis. You see, isopropyl alcohol does not cause metabolic acidosis as opposed to methanol, or as opposed to ethylene glycol, as opposed to ethanol. Why is that? Any idea why does not isopropyl alcohol cause metabolic acidosis? Any of the postgraduates? Why would a isopropyl alcohol does not cause metabolic acidosis as opposed to lactate, alcohol, methanol, ethylene glycol? You see, the end product of metabolism of methanol is formic acid. For ethylene glycol is oxalic acid. So these are all acids, where isopropyl alcohol is converted into acetone, which is released by the lungs. So isopropyl alcohol does not cause acidosis. So if you are given a metabolic acidosis with an osmolar gap and all, never write isopropyl alcohol. It does not cause metabolic acidosis. Okay. Let's take this case. A 70-year-old woman with a history of prior ventral hernia repair with mesh is admitted to the ICU for a small bowel obstruction requiring serial examination. The patient had a nasogastric tube, started IV hydration. During the next 24 hours, the pain worsens and there is a significant bilious drainage from nasogastric tube. So small bowel obstruction, got a nasogastric tube, and this is the patient's labs. Sodium 149, potassium 3.3, chloride 105, creatinine high, BUN is high. This is the albumin. So looking at the lab values, let's see, do we have an ABG? Yes, we have an ABG here, pH 7.50, PCO2 24, bicarb is 17. So you see, if you just look at the pH, this patient is alkaline, right? But if you look at PCO2, this is respiratory alkalosis. CO2 has gone down and the bicarb is also. But if you look at the anion gap, if you just look at this, then you would have said, okay, this is a case of respiratory alkalosis. But if you look at the sodium, potassium, and chloride and bicarb, there is an anion gap in this patient. This is chloride, this is bicarb. So there is an anion gap acidosis along with respiratory alkalosis in this patient, which was hidden. Just by looking at this, you could have said this patient has acute or chronic respiratory alkalosis. But by looking at this, you could say that there is a hidden anion gap acidosis. So the normal anion gap is 12. So is there anything else in this patient? Is there anything else going on in this patient apart from high anion gap metabolic acidosis and respiratory alkalosis in this patient? This is done by what is called the delta gap. Now the normal anion gap is 12. So the delta anion gap in this patient anion gap was 27. The normal is 12. So the delta gap is 15. The bicarb in this patient was 70. So delta bicarb is 7. So you see, in a simple anion gap metabolic acidosis, the bicarb should have come down by 15. So 15 by 15 should have been 1. Bicarb has not come down till 15. So there is this is 7. Bicarb, the delta bicarb should have been 15. So the bicarb should have been 2 in this patient. Instead of 2, it is 7. That means there is more bicarb than what there should be. So this patient has triple disorder, acute respiratory alkalosis. Just by looking at this, you can say that. By looking at the anion gap, you can say this patient has high anion gap acidosis, this patient has 27 anion gap. And by looking at the delta-delta gap, you would say this patient also has metabolic alkalosis. What could be the reason for all this? This is a mixed acid-base disorder. Let me just share my screen again. কৌশিক দেখা যাচ্ছে স্ক্রিন মাঝখানে চলে গেছিল
হ্যাঁ দেখা যাচ্ছে
I will come back to again this case. Okay, so this patient has mixed disorder. She has worsening sepsis from an ischemic bowel leading to metabolic acidosis, which is lactic acidosis. This can explain the high anion gap acidosis. She has metabolic alkalosis because she has got nasogastric drainage, has been vomiting, and because of her tachypnea due to abdominal pain and hyperventilation, she has respiratory alkalosis. So you see, how do you manage this patient? You have to control the respiratory alkalosis by managing this patient's pain. You have to give some opioids to this patient. How do you manage metabolic alkalosis in this patient? You have to hydrate the patient. You have to ensure that the vomiting is not there. You have to give antiemetic to these patients. And how do you ensure to correct this is to correct the underlying disorder of ischemia. So each of this has a therapeutic connotation. So once we get the numbers, I think you need to analyze these numbers in a better way. And you have to come back to your patient, try to fit in the abnormalities that you have find in the patient to the patient's condition, and then try to correct those conditions. Okay, again, can we use this strong iron difference to simplify the whole thing? Let's come to this. Sodium 149, chloride 105. So that is 44. So immediately I can say this patient has metabolic alkalosis, right? More than 40. Now I have to explain this 44 by bicarb and by albumin. Let's see whether we can do. So you see, within a simple minute, 1 minute, I can say what is the metabolic acid base in this patient is. Sodium minus chloride. Sodium was 149. Chloride was 105. So it is 44. So this patient has metabolic alkalosis, no doubt about it. Can I explain this 44 by bicarb? Bicarb is 17. Albumin was 4, so it is 12. For each gram, I have to add 3 milliequivalent. And the normal anions are 5, so 34. So I cannot explain this 44. That means this patient's albumin, bicarb, and strong anions can only explain 34 out of 44. So there has to be 10 more strong anions floating around. This 10 more strong ions could be lactates, could be keto. That then you have to see what could be the other ions which are floating. So immediately you know this patient has metabolic alkalosis with high anion gap metabolic acidosis. Okay, the respiratory component you have to deal separately by looking at pH and PCO2. So this I have to look at pH, PCO2, but for these two, I just need the sodium, chloride, and bicarb, and I would be able to know that this patient, and I think this is a much easier way. So I think the chloride is not being done very routinely, so that usually becomes an issue. Okay. So remember, another way of looking at and calculating a mixed acid-base disorder is to look at the sodium chloride, see the difference between sodium chloride, more than 40 metabolic alkalosis, less than 40 metabolic acidosis, and whatever the number you get, you have to explain that number by bicarb and albumin. And then you have to decide if there is some other hidden ion difference. Okay, so these are the few examples that I have told you and we have interacted. Now there are certain rapid fire exercise rounds. So let's see. Now, simple, if you have a normal PCO2 and a high pH, what is the underlying problem? Normal PCO2 and a high pH.
Somebody says dehydrated.
Since there are 150 participants, I think is different. Too difficult হবে অনেকজন তো দিচ্ছে. So basically, a high pH means there is alkalosis. So this is metabolic alkalosis with respiratory alkalosis. Whenever you get this combination, high pH is alkalosis, and PCO2 will become normal if the CO2 in respiratory alkalosis, it goes down. Metabolic alkalosis, it will go up. So PCO2 will become normal. What about normal PCO2 with a low pH? The possibilities are respiratory acidosis with metabolic acidosis. Both of them are acidotic. In metabolic acidosis, the PCO2 will be low. In respiratory acidosis, the PCO2 would be high. What about normal pH with a high PCO2? Normal pH with a high PCO2. This can happen with respiratory acidosis and metabolic alkalosis. The pH will become normal, and both of this will cause high PCO2, both respiratory acidosis and metabolic alkalosis. This is easy. You get a high pH with a high PCO2 is metabolic alkalosis. Both are high. If you get a low pH and a high PCO2, this is respiratory acidosis. Now, low PCO2 with a normal pH, what are the possibilities? Metabolic acidosis with respiratory alkalosis. Again, acid base will counter each other and both will cause low PCO2. High pH with a low PCO2, this is caused by respiratory alkalosis. High pH with a low PCO2. And low pH with a low PCO2 is metabolic acidosis. So just by looking at the pH values and PCO2 values, you can have a reasonably good idea as regards what is the underlying acid-base disorder is. Just again a quick thing, so let's see the first one. PCO2 28, pH 7.32, bicarb 14. So this is definitely a metabolic acidosis. pH is low, PCO2 is low. If it was pure metabolic acidosis, this should have been 32. So 28, well, plus minus. So this can be a pure metabolic acidosis. pH 7.47, PCO2 20. So this is respiratory alkalosis. Now bicarb is 14. So this is respiratory alkalosis with metabolic acidosis. If you calculate, you will find that in acute respiratory acidosis, the bicarb should not have gone down so low. So this is another way to look at quickly at these things. Now, the last this last exercise that we have is this one. Now, you have to match this 1, 2, 3 with the etiology. So let's just go through this and try to match. 1 is A, B, or C, 2 is A, B, or C, and 3 is A, B, or C. See, I will give you 1 minute for this. What is 1? All 3 had normal aniongap acidosis, as you could see. Let's see if I get some answers here. 1 is B, 3 is A, Somebody is saying one is A, two is C. Okay. Okay. So I think the most important thing is here, is it positive or is it negative? As you know, a positive urine anion gap is renal tubular acidosis, or it's normal. So this has to be either type 1 or type 4, is 2 or 3. Diarrhea have a negative urine anion. The reason for this is, in diarrhea, the excretion of acid by the kidney. In fact, before this meeting, we were discussing, Professor Ganguly had mentioned, we are vertebrate because kidneys are able to excrete acid. Now, diarrhea due to laxative use, the kidney still preserves the capacity to excrete acid. So the ammonium, and as you know, in diarrhea, there is metabolic acidosis. So if there is a lot of metabolic acid, this acid is excreted through the kidney as ammonium ion. Kidneys cannot excrete hydrogen ion as such. It has to be combined with some other ion. So ammonia is the one. So kidney excretes like ammonium chloride. So ammonium ion. So the urine anion gap is sodium plus potassium minus chloride. We cannot calculate ammonium. So ammonia becomes very high. Ammonia becomes very high. So sodium and potassium becomes low. So urine anion gap is negative in diarrhea. So one is B, there's no doubt. Whereas in renal tubular acidosis, either due to bicarb loss, that is proximal renal tubular acidosis, where bicarb is not absorbed, or distal renal tubular acidosis or type 1 renal tubular acidosis, where acidification mechanism of the body is lost. In both of these, the urine anion gap remains positive. In hypoaldosteronism, that is type 4 renal tubular acidosis, as it signifies hypoaldo, the potassium is high. So as soon as you get a high serum potassium with non-anion gap metabolic acidosis, with a high urine anion gap, this is very suggestive of type 4 RT. So 1 would be diarrhea, 1 B, 2 will be C, and 3 will be A. There the potassiums are usually low. In order to differentiate type 1 and type 2 RTA, urine pH is sometimes resorted. Okay, so look at the bicarb, look at the sodium, look at potassium, and look at the urine anion gap. So I think it is important. These are the things that you need to look at. So let us just summarize what we discussed in these 2 lectures. And then I will hand it over to Professor Ganguly for his summary. Now, 10 rules of blood gas interpretations. The first is, are the numbers valid? As we discussed you can look at Henderson's equation. So with that, you calculate the hydrogen ion, and you convert it to pH. 80 minus hydrogen ion should be last 2 digits of pH. But this is not done nowadays because the blood gas machine will tell you that the numbers are not valid. Second is, look at pH only and see whether it is acidemia or alkalemia. Because there can be a mixed disorder, but the primary disorder is established by the direction of pH. It is either acidemic or alkaline. So look at pH and decide whether it is acidemia or alkalemia. Then look at CO2 to see whether it is metabolic or respiratory acidosis or alkalosis. So look at pH first, then look at pH and PCO2. Then look at your bicarb. Look at the bicarb will tell you whether you can fit in the bicarb with simple or mixed acid-base disorder. If the bicarb is not fitting in with simple acid-base disorder, then there has to be a mixed disorder. In a mixed disorder, then you have to see whether there is metabolic acidosis. You have to look at anion gap or non-anion gap or mixed anion and non-anion gap acidosis, you have to look at sodium and chloride apart from bicarb. In an anion gap acidosis, always look at osmolar gap by looking at measured serum osmolality and the difference with calculated osmolality. In non-anion gap acidosis, you should always look at urine anion gap by looking at urine sodium potassium chloride. In a case of metabolic alkalosis, you should look at urine chloride to see whether it is chloride responsive or unresponsive. In respiratory acidosis or alkalosis, you should have applied the rule of 1, 2, 3, 4 to know whether it is acute or chronic respiratory acidosis or alkalosis. And you should always interpret these numbers by looking at the clinical context, by seeing what type of patients you have and how do we interpret these numbers back to our patients. So we have 8 or 9 minutes left. So I will hand it over to Professor Ganguly for his summary and if he wants to moderate any question and answers.